Now we're going to be talking about esophageal atresia with tracheoesophageal fistula. This picture, and I know if you make it bigger, it's a little bit easier to understand, but if you turn to page 417, this is the most common type of esophageal atresia and tracheoesophageal fistula. And it gives you that atresia just means there's that blind ending of the esophagus. So as you can imagine, all the secretions, the baby drinks, and all those secretions will then be thrown up, or the baby won't be able to drink and digest any foods. So we have feeding, which causes that regurg, coughing, constant flow of saliva, gastric distension. Especially the gastric distension comes in when you have that opening between the trachea and the fistula, because taking in a breath, well, the air will go down into the stomach, as well as some of it will go into the lungs as well. So these are congenital malformations in which that esophagus terminates before it reaches the stomach. And or they can have a fistula, which is an abnormal opening, is present that forms an unnatural connection between the esophagus and the trachea itself. These are all different forms of tracheoesophageal fistula with atresia, but the most common is the one that they mention in your book. The signs and symptoms is, number one, is failure to pass the suction catheter or NG tube at birth, excessive oral secretions, vomiting, abnormal distension of the abdomen. They can have an airless scaphoid abdomen, especially if they have atresia without the fistula. So remember, the fistula causes air to go into the abdomen, whereas if they don't have a fistula, then they'll have a very flat scaphoid abdomen. And remember, this is real important because we want to remember the 3 C's with our babies: coughing, choking with feedings, and cyanosis. Those are the 3 important things that you will see with these little kiddos. Esophageal atresia and tracheoesophageal fistula represent a critical neonatal surgical emergency, and it's very, very important that you prevent, as a nursery nurse, prevent any type of aspiration. So on our diagnostic assessment, if the mother has had any history of maternal polyhydramnios, that is a very significant prenatal clue. If TEF is suspected prenatally, the diagnosis can be made at the ideal time, and that's in the delivery room itself. Atresia should be suspected if an NG tube cannot be passed 10 to 11 centimeters beyond the gum line. This usually is confirmed with an abdominal radiograph X-ray that will identify a proximal esophagus dilated with air, and that's that atresia, or abdominal distension, which then would indicate that fistula. The radiologist can identify the specific type of defect after instilling less than 1 ml of water-soluble contrast into the NG tube in documenting its movement into the tracheal tree and into that proximal pouch. This is then withdrawn from the pouch to minimize the risk of aspiration. Bronchoscopy, endoscopy are also used to identify and assess those fistulas. And also the infant will need to have other diagnostic testing for any other common abnormalities that are seen, such as cardiac and any other congenital anomalies that are often seen with TEF and esophageal atresia. So under our management of this baby, we want to keep the infant infant supine with the head of the bed elevated, which decreases the chance of gastric secretions entering the lungs. An NG tube may be in place and aspirated every 5 to 10 minutes to keep the proximal pouch clear of secretions. IV fluids are very, very important. Surgical repair is the mainstay of treatment. Initial repair includes litigation of the fistula and end-to-end anastomosis of the atresia to decrease the severity of the stricture formation. If the gap between the two parts of the esophagus is too large, then a primary anastomosis may not be possible. So what they'll do is they may have to have a stage repair, and they may have to put in a G tube and a cervical esophagostomy are placed. So later, anastomosis, colon, they use the colon for part of the esophagus later, and dilation can be expected. Evaluation and treatment of esophageal motility dysfunction, GERD, strictures, bronchitis, and pneumonia may occur, of course, as the child gets older. So on assessment, this child, we have to make sure that we keep the child from aspirating. We have to examine the infant for excessive oral secretions, choking, cyanosis, difficulty swallowing, regurg, vomiting, any unexplained cyanosis after initial feed, who's not diagnosed at birth, or important assessment findings that needs to be reported to the physician. Any abnormal distension should be measured, and the infant continually assessed for any kind of distress, vital signs, respiratory effort, any nasal flaring, retractions, or any cyanosis. Under our nursing diagnosis and planning, which is on page 418, this patient is at risk for aspiration. Also at risk for imbalanced nutrition, less than body requirements, risk for impaired skin integrity related to the G-tube, risk for infection related to the surgical repair, acute pain, anxiety, especially parenteral anxiety, and deficient knowledge related to home care. So in our interventions, we want to make sure that we keep this baby very warm. We want to keep him and administer O2 as essential to relieve any kind of respiratory distress. We want to make sure that the patient, of course, is NPO. We minimize that risk for aspiration by keeping the child at least at a 30-degree angle. Suction catheter is right there. And sometimes what you'll have to do is you just have to suction PRN. It's important to keep in mind that even after surgery, that these children are prone to gastroesophageal reflux. So in our post-op period, in the immediate post-op period, we want to monitor respiratory status, support fluid balance and nutrition, maintain thermoregulation, so we're going to be doing vital signs frequently, providing pain relief, monitoring for infection, and promote that bonding with the parent. The child will probably have a chest tube in place. They'll be in pediatric ICU. You have to keep patency of that must be monitored. Suction is monitored. Output, of course, is monitored. Respiratory rate, presence of any abnormal breath sounds should be documented. We have to maintain temperature, IV fluids, antibiotics, parenteral nutrition may be ordered as well. We have to maintain the IV line, I&O, assess for any signs of fluid electrolyte imbalance. Of course, daily weights, measurement of head circumference can aid in assessing growth. Pain medications must be administered as needed. We want to make sure that, especially in the immediate post-op period, if they have a G-tube, gastrostomy tube, that is usually left open to drainage in order to allow any gastric contents and air to escape, which promotes that comfort and decreases risk of pressure at the anastomosis site. Pacifier usually is needed for sucking, and they'll use different. You see a picture on page, which is figure 19-3 on page 418. It gives you kind of a picture of what this patient may look like when he comes back from surgery, but there's a skin level G-tube button, which is a McKee, and that's usually what they use in these little infants. Home care, they should be taught the techniques of G-tube feeding, and the home care is on page 419, patient-centered teaching. They make sure that for new gastrostomy, clean the site daily with soap and water, and if crusty, they can use that half-strength peroxide to clean it, usually with some normal saline, and apply any kind of antibacterial ointment if indicated. They need to gently rotate or turn the tube every day. After 1 to 2 weeks, tub baths may be used to clean the site. Stomaadhesive protective powder can be used to decrease the moisture. Keep the tube open during the initial postoperative period, and while the site is healing, make sure the tube is stabilized. Proper stabilization technique will vary depending on the type of gastrostomy tube that the baby has, and the physician's orders as well. When the tube is well healed, it can be secured with specific tape. Use skin barrier around the stoma to prevent any skin breakdown, and report any type of drainage, leakage of formula, redness, or pain to the physician. And usually this is done in a big teaching hospital, so they have interstomal therapists for help in making those types of good choices for the child. And always remember to remind them to use that pacifier for their children. So on evaluation, we're looking at, can the child coordinate sucking and swallowing? Is the child tolerating oral feeds without choking, coughing, or becoming cyanotic? Is the child growing according to the growth chart? Is the surgical site clean, dry, and intact, free of redness, drainage, or any exudate? Is the skin intact and without any breakdown around the gastrostomy tube and the esophagostomy tube? Is the child resting contently without pain? And can the parents explain the need for the surgical procedure, and do the parents demonstrate an appropriate care of that G-tube? And have the parents assumed all those care responsibilities, especially before they go home from the hospital. We're going to start talking about the child with the GI alteration. And the first one that we're going to be talking about is cleft lip and palate. And cleft lip, cleft palate, and cleft lip and palate together are separate anomalies that are closely related in the etiology, the pathophysiology, and the nursing care. And these distinct problems are all abnormal openings in the lip or in the palate. The defects may occur unilaterally on either side or bilaterally, and are the most common congenital craniofacial deformity. This is in your PEDS book. It's chapter 19. You'll see another picture on page 413 of a little baby with a cleft lip and palate before, and then you'll see the little guy afterwards. He looks really cute. He's a little shy guy. Cleft lip is that notched I can never say this word right, vermilion border cleft that involve the alveolar ridge and the dental anomalies. Cleft palate includes the nasal distortion, midline or bilateral cleft with variable extension from the uvula, soft and hard palates, and exposed nasal cavity. And the first sign may be in the infant, may be formula that's coming from the nose. The diagnostic is based on observation at birth, and complete exam is included in that neonatal period, which is very, very important. A gloved finger is usually placed by the physician in the mouth or by the nurse as well when the child is still in infancy, and looked to feel that defect of the palate, or they can use a visual exam using a flashlight to confirm the diagnoses. Assessment is done. We assess the infant's ability to suck, swallow, breathe without distress, and usually they should be able to handle those normal secretions. Assess and record the parent's reactions as well as the interaction with the neonate. Provide information about the causes of the defect, and encourage bonding through that touching and holding and examining their newborn. And it's always good to point out the newborn's positive attributes. On our interventions, we want to describe basically our therapeutic management is based on the severity of the defect. And the first intervention involves modifying feeding techniques as needed to allow adequate growth. So we have use of special feeding techniques, obturators, unique nipples, and feeders can usually accomplish this goal and allow early discharge home with the parents. Figure 19-1 gives you an example of one of the types of special feeding techniques. Is this bottle compresses. It'll compress on all sides, allowing gentle squeezing of the sides of the bottle to help eject the breast milk or the formula into the baby's mouth. Sometimes a slight longer nipple allows the milk to be swallowed with less chance of milk entering that nasopharynx and without stimulating that gag reflex, which is real important. As you'll see on the patient-centered teaching, home care of the child with cleft lip or palate, I'll go over some of those, and those are all important, especially when you're teaching the parents about the specifics of how to feed their child and how to manage them at home. So we also we want to make sure that we modify those feeding techniques. We provide alternative assistive feeding devices, hold the infant in a more upright position, burp that infant more frequently, write down feeding program for the parents to use at home, and we'll go over that in a few minutes. Provide emotional support and positive reinforcement to the parents. Keep and record child's growth. And it really takes a team to take care of these types of patients. So you'll be looking at the nurses, the geneticists, psychologists, psychiatrists, ears, nose, and throat specialists, audiologists, OT, PT, usually OT, not PT, OT, and speech therapists. So you'll be seeing those, and you may see a device, what they call a Latham device. I know that my oldest had to have one, not because of cleft lip or palate, but it's a device, it's an orthopedic device that they put in the mouth, and it's used to expand and realign the upper palate and teeth. Explain pre-op and post-op procedures, and that's real important because cleft lip repair is usually performed by age 3 to 6 months. That early repair may improve bonding and make feeding a lot easier. Some cosmetic modifications may be needed again at age 4 to 5 years of age. And That's cleft lip. I think I already went over that. And cleft palate repair is individualized, and it is based on the degree of the deformity and the size of the child. And closure is usually completed between ages 6 and 24 months. And most of the teams recommend repair by age 1 or earlier closure, because earlier closure facilitates speech development, and that's real important. So if they've had to have surgery, it goes over our oral feedings will be withheld for 6 hours. An IV line, of course, is going to be placed, and post-operatively, we're going to make sure that we keep straws, pacifiers, spoons, or fingers away from the child's mouth for about 7 to 10 days. Do not take any temperatures orally, so they'll either be axillary ordered or they'll be rectally ordered. It just depends on what the physician wants. Advance the child's diet is tolerated from clear liquids to soft diet, usually within 48 hours. That will be done. Our nursing diagnoses for children with cleft lip and palate is alteration in nutrition, less than body requirements related to the inability to suck. So our goal is the child will drink the recommended amount of feeding within the 30 minutes without, getting so tired and worn out from working so hard to eat. Knowledge deficit about feeding techniques and surgery related to unfamiliarity with the information. And our goal is to have the parent understand expected pre-op and post-op feeding techniques. Our home care of the child with cleft lip or palate is on page 414 in chapter 19, and it basically just goes over the special needs of the child for feeding while they're awaiting surgery. So if you look at the different bullet points, I'll go over those. Breastfeeding may be possible if your child has a small cleft lip or palate. A soft plastic compressible bottle, which is in figure 19-1, will prevent your child from having to suck vigorously because the breast milk or formula can be squeezed directly into the mouth, and that's what we talked about earlier. A longer nipple may allow the milk to be swallowed without entering the nose. But it has to be not so long that it causes gagging. Enlarging the nipple hole, and that's what we used to do in pediatrics. We enlarged the nipple hole. We did a cross-cut. Nipple can also be effective. A syringe with a rubber tip may also be used, especially after surgery. They may use that. Feed your child slowly. Provide short periods of rest for swallowing. Children usually develop a feeding pattern of sucking, swallowing, and resting that really helps them become more efficient type eaters. Try to keep your child upright position to decrease the chance, of choking. Burp the child very, very frequently because a lot of excess air is often swallowed. So before the surgical repair, devices may be placed in your child's mouth to help line up the cleft in the palate for better surgical repair or to decrease the size of the lip cleft. And these devices may require special care and cleaning, and make sure that the parent knows what that cleft team and nurses need and want for specific instructions about that device. After surgery, these children will have elbow restraints, also called no-nos, may be used so that your baby cannot touch the stitches, and the following are recommended. Do not apply the restraints too tightly. They should be loose, but still prevent that elbow bending. Remove the no-nos every 2 hours for 10 to 15 minutes in order for the parent to look at the arms. Look for any skin irritation and allow playtime. And also it's important for them to remember to remove only one restraint at a time. Make sure that they are taught to Position the child on the back so the child does not rub the stitches on the linens. An infant seat can be used. It's important not to brush the child's teeth for 1 to 2 weeks after surgery. A small amount of water feeding after meals will help keep the teeth clean. Clean your child's lip as recommended by the physician. If ordered, you can use a cotton swab and a gentle rolling motion down the suture line, and then apply an antibiotic cream or ointment using the same technique. Make use of any kind of support professionals in the area, and they can also, I think it's a good idea to have them contact the American Cleft Palate Craniofacial Association and the Cleft Palate Foundation, even if they just go online to check for it. There's a very good nursing care plan that kind of breaks down a lot of the things that we went over. I&O is very, very important with these little kiddos. Weight is very important. Making sure that they take care of the surgical site afterwards and they have the correct directions for it, and it goes over that in that nursing care plan as well. Okay, that will be the end of cleft lip and cleft palate.